my name is Shreya Ganguly, and I am presenting a project entitled Didactic Curriculum Co-Creation for the Community Learning and Social Medicine course. The Community Learning and Social Medicine, or CLSM course at Emory, currently involves direct service learning and community engagement with community-based organizations in the Metro Atlanta area, as well as didactic curriculum centered on social determinants of health. The didactic content was created by a team of physician faculty members and tackles topics such as structural violence and immigration-informed healthcare. We aim to create a process for third and fourth year medical students to co-develop didactic content for the CLSM course with faculty members, with the knowledge that they could highlight information and resources particularly important for students on clinical rotations. We first created a team of 7 M3 and M4 students who had played an active role in community engagement during medical school. We then assigned a student lead to each CLSM didactic activity. Students partnered with CLSM course faculty to co-create and deliver didactic content. They also provide feedback on M2 community projects and assisted planning for an annual community engagement day. Overall, this curriculum co-creation model offered medical students a unique opportunity to work alongside physician faculty to contribute to the education of their peers. It enabled students to autonomously contribute to course content and suggest new directions for the course. It also helped foster a supportive learning environment using the power of near-peer teaching. In the future, we hope to improve this model by recruiting students early enough to serve as facilitators over multiple years and train new mentors. We also hope to provide input on community projects during the M1 development phase and strengthen relationships between faculty and near-peer facilitators through long-term collaboration. Thank you.
Hi, my name is Antonia Oliveira. I'm a first-year medical student, and today I'd like to share the results of an initial assessment of medical Spanish training interest at Emory School of Medicine. So, of note, medical Spanish curricula varies greatly across U.S. medical schools, with only 21% meeting expert-defined criteria. Despite there being concrete data showing the benefits of language concordant care for Spanish-speaking patients. Moreover, being able to provide this type of language concordant care is a goal that many Hispanic and Latino students share. So with this in mind, we wanted to make an initial assessment of Emory medical students' current role in clinical care of Spanish-speaking patients and the interest in a more like formal medical Spanish training. So to do this, we conducted a survey assessing demographics, Spanish fluency, interpretation skills, and Spanish use in clinical settings, and also the availability and barriers to assessing medical Spanish courses at the school. So what we did was we created a survey and they distributed it to Emory's Latinx MD student affiliation group, and we obtained 12 responses. And some results that I'd like to share from the survey is that 70% of respondents indicated being native Spanish speakers and 20% advanced Spanish speakers. And then as you can see here, 75% indicated that they have spoken with patients in another language besides English in a clinical setting. 67% said that they have had to interpret or translate medical information from English to another language. And 75% said that they've had to interpret or translate from medical information from another language to English. And also some like challenges that they described that I'd like to highlight. First is when translating, they struggle sometimes with understanding a regional dialects. They also experience some difficulty with medical vocabulary. 58% heard an inaccurate interpretation by another provider or certified interpreter. And also many felt pressure from the clinical team to interpret, around 50% of students. Also, interestingly, more than 90% indicated that they envision themselves speaking in another language other than English in the future as physicians. And I'd also want to share what students explain are the ways that they can have some sort of medical Spanish training at the school. So what they indicated was current student-led workshops, an undergraduate medical interpretation group, and a now discontinued medical Spanish elective. So what we can conclude from this initial assessment is that the current medical Spanish training is limited to student-led workshops and an undergraduate interpretation group, despite students not only speaking in Spanish in a clinical settings, but also having an interest in a more formal medical Spanish training. So taking all this information into account, what we aim to do next is assess if this interest in a more formal medical Spanish training extends to the whole medical student body, not just the Latinx students. So this is what we have to share, and thank you all for your time.
Hello, everybody. Today I'll be highlighting the profound relationship between medical complexity and the social determinants of health that often operate silently yet decisively in shaping patient outcomes. Our team examined a case of a 40-year-old man with a recurrent retroperitoneal abscesses and how his socioeconomic constraints influence his clinical course as much as his underlying pathophysiology. Our patient was a 40-year-old man with a past medical history of cyclic neutropenia, leukemia as a kid, and general ureter abnormality. He presented with fever and back pain, a presentation similar to several prior admissions dating back to 2021, with the same diagnosis of recurrent abscesses in the retroperitoneal space. He'd currently been admitted just a few weeks prior. At that time, he was managed with a percutaneous drain and broad spectrum antibiotics. The drain was subsequently removed due to the request of the patient to return to work. During his latest admission, our goal was twofold: manage the acute abscess and understand the etiology of why they were recurrent. We considered multiple angles. Our differential started with the anatomic structure. Could his anatomy predispose him to recurrent back abscesses with his history of acute pancreatitis? The fistulogram showed that the small bowel was tethered to the right kidney, though follow-through imaging didn't confirm a fistula. He was recommended to follow up outpatient with colorectal surgery. From the hematological standpoint, the patient endorsed a history of childhood leukemia. This prompted us to consider whether or not prior treatment or perhaps an undiagnosed underlying immunodeficiency could be predisposing him to recurrent infections in adulthood. Collateral from mother revealed a diagnosis of pre-leukemia as an infant, but the family decided not to pursue further follow-up. From the social lens, the patient had received treatment at multiple outside hospitals, but previous teams at Grady lacked access to those medical records. He reported that he often couldn't complete treatment due to financial restrictions and job security. After further investigation from outside hospital records, it was found that the patient's prior infection showed mixed bowel flora, raising the possibility of a microperforation as the root cause. General surgery was consulted, but surgical intervention and treatment was not pursued by the patient due to the financial burden of extended time off of work. Clinically, the patient improved with improvement of drainage of the abscess, appropriate antimicrobial coverage, and CT monitoring for the resolution of the abscess. The drain was removed and PO antibiotics were given to the patient at discharge with plans for outpatient follow-up. Unfortunately, he missed the outpatient follow-up appointments and he returned to the hospital admitted 2 months later with another abscess, but pursued early discharge due to a personal emergency. This pattern of clinical progress and improvement being undercut by the socioeconomic instability is not merely an unfortunate, is not only unfortunate, but it represents a broader challenge we face in delivering equitable care to all of our patients. So our takeaway is that in complex and recurrent cases, medicine in isolation is insufficient. Our efforts must extend beyond the differential diagnosis and imaging studies, and we should collaborate with social work, access outside medical records, and listen to the patient's lived experience that shape their medical decision making. In the end, we are reminded that treating a disease is only half the work. The other half is understanding the context in which the disease reoccurs. Thank you.
Hi everyone, my name is Tyler Williams and I am a first-year medical student here at the Emory University School of Medicine, and I'll just be chatting with you very briefly about some of the work that I've been doing as a part of the Elementary Pediatric Health Curriculum, or EPHC. So here at EPHC, we just want to acknowledge and stress the importance of early intervention in lifelong healthy habit formation, particularly in students of color and also underrepresented socially and socioeconomically disadvantaged students as well. And so as a part of EPHC, I have been a part of a team that has been looking to help bridge this gap in health literacy among elementary age school children by utilizing AI. And so as part of our intervention, we have been teaching a healthy habit curriculum throughout this past year at the Burgess Peterson Academy, which is a public school here in Atlanta that has a 65% minority and 31% economically disadvantaged student population. And so, in addition to the curriculum that is taught in school, we have been developing videos that the students can bring home, which we are hoping will help reinforce these healthy habit formations outside of the classroom as well. And so these videos that we have been creating have been culturally competent and include a wide range of cultural and age, of different cultures and ages, so that we can reach a broad audience here in Atlanta and a broad audience here at BPA. The hope is that by using the blueprint that we have established with using Powtoon, the cartoon creation website, and also with the health teaching plan that we have been teaching at BPA, we can expand to other schools throughout Atlanta and hopefully nationally as well. And so as a part of the videos, we are offering an innovative message that is providing a engaging and personalized interactive content that enhances the comprehension and retention, especially amongst underrepresented and traditionally ignored and forgotten demographics. And so, like I said, we are hoping that this will be a blueprint for a national elementary health literacy program, since, at least right now in Georgia, there is no standardized curriculum for healthcare education. And we know that healthy habits lead to better lifelong outcomes, both for physical, mental, and social health. So this approach does have the power to potentially change and transform U.S. health education. And so thankfully, through the anecdotal evidence that we have been receiving, we are noting that students are having an easier time recalling and applying the concepts of healthy habit formation that we have been teaching them all throughout the year. And we have been asking parents and the students both, and we have been receiving the same feedback in all of the surveys that we have been sending out. And so the use of these videos does help to amplify EPHC's goal of healthy habit formation reinforcement outside of the classroom. And so we're very happy to announce that through the BPA program, we have been given full license to expand into about 5 other public elementary schools here in the Metro Atlanta area. So we're very excited about all that is to come, and we're very excited about our ability to help bridge this health literacy gap by creating these culturally competent videos utilizing the power of AI. Thank you.
Hello, we're with the Institute for Healthcare Improvement Open School chapter here at Emory University, here to present our poster on student-led interdisciplinary case competitions, or SLIC, to improve education on health disparities. We can all agree that undergraduate and graduate students are interested in addressing health inequities, but face challenges in getting adequate experience. There are multiple challenges to implementing health equity education in the medical curriculum that have been cited in literature, including limitations on the integration of current events, need for more active learning, and the siloed educational experience. Case competitions, on the other hand, offer students an active learning opportunity in a condensed time frame and naturally address challenges in health equity education by encouraging students to explore current healthcare issues. The objective of our study is we wanted to evaluate the efficacy of interdisciplinary case competitions as an approach to improve health equity education in medical school. We sought to foster student interest and engagement in the topic by challenging them to address real-world healthcare issues through innovative and strategic problem solving.
So we established the Emory Institute for Healthcare Improvement Open School Student-Led Interdisciplinary Case Competition, otherwise known as IHI SLIC, in 2022 to serve as this interprofessional forum to better engage students in learning about health equity challenges and how to develop innovative solutions to them. We paired teams with interdisciplinary members consisting of 3 to 5 members from 2 distinct specialties. And we had them compete as a team over the course of 6 weeks, addressing a case prompt that we drafted, with the 5 finalists presenting in person to the final presentation in order to win a cash prize.
From the inaugural case competition in 2022 to the 4th one in 2025, student participation grew at a rate of 59% year-on-year, institutional representation at 170% year-on-year, academic disciplines 112% year-over-year, and interdisciplinary teams at 66% year-over-year. The expanded case prompt scope allowed a greater range of solutions, ultimately leading to greater health equity education. Below you can see the case prompts from 2023, 2024, and 2025, along with the problems and solutions proposed by finalist teams. For example, in 2025, students were challenged to address a climate-related challenge in healthcare, and the winning team chose to address the increasing range of tick-borne illness in the Southeast through deer tick treatment, state park bulletins, and an illness registry. Case competitions ultimately encourage deep learning, tapping into health profession students' interest in addressing large-scale health systems problems. Some limitations include finances. Other institutions may not have the funds to run an event like this. And this personalized approach to health equity education, where students find a problem they're interested in, conflicts with the standardized approach that lecturers provide. Overall, the Institute for Healthcare Improvement student-led interdisciplinary case competition succeeds at integrating health equity education into medical school in line with recommendations from prior literature by eliminating standalone lectures, integrating current events, and adding cultural context. Thank you.